Good afternoon, everyone. This is the next webinar in the series, which all emanates from the work that the IFOA has done over the last year in terms of trying to better understand and better communicate a variety of different aspects relating to the COVID pandemic. And I'm very grateful to the ICAP committee for the opportunity to share here today with you on the topic of social care. My name's Dan Ryan. I'm the Chief Science Officer of Koios Research, a research think tank which is looking at demographic risk and behavioral science. And for the last 25 years, been looking at various different data sets, trying to better understand what they tell us about the future at the intersection between medicine and actual science. And today, we're going to focus on social care. And particular topics focused on relate to the way in which we've seen outbreaks across the UK and across the world, bringing in learnings from outside, and looking at how going forward, care homes have had to change and will change to prevent further pandemic outbreaks and the threats that the whole pandemic has posed to the care home sector and what it means to long-term funding. And obviously, long-term funding is a topic which the IFOA and the actual profession more generally has spent many years commenting on, cajoling, and trying to understand. But I'm delighted that so many are able to join from many countries around the world. And please, 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 as I go through these slides, if you have any questions, please put them on the question and answer, and then we can talk through them during or after the presentation. So my history in terms of and why I'm particularly interested in social care goes back to 1998. And this slide in front of you here shows you what was the first continuing care retirement community in the UK in a place called Hartwick Oaks, which was run by the Joseph Rowntree Housing Trust. And that was bringing to the UK a concept which was well known in the US and other countries, and indeed had a tradition related to particular groups, whether it was religious or occupational. But this was the first in the UK which was effectively bringing everyone together. And the individual houses where people lived gives you a very strong indication of how this particular organization worked. It was to provide as much care as possible, as needed, to people when they needed it, with the intention of trying to keep them in their houses for as long as they could. And when more care was needed, then they would move towards in the center of the village where there was a nursing facility. And that balance, that kind of symmetry, is something which increasingly people want. But obviously, many people need nursing home care. But if we look at the totality of who needs care, these figures from a variety of different sources give an indication that roughly 1.5 million people in the UK need some form of care and support at home in elderly people. And that about 400,000 of them are in actually kind of residential and nursing homes. And that obviously has two implications. One, an enormous amount of organization to achieve that, but also an enormous commitment, both in terms of formal caring and, very importantly, informal caring. And during the pandemic, we have seen an enormous number of people having to be looked after, having to provide support to individuals in a variety of different settings, often in a situation that they'd never experienced before, and a very challenging and difficult time. And as we go through the slides, I really want to give a little bit of sense as to how both at home and in the care homes, individuals did not receive as much attention in the early phase, and how that led to some of the tragedies that we have now learned about. So the Department of Health put together, the Department of Health and Social Care has many different facets, but over on the right-hand side here, social care you can see as a very, very important piece, but one which perhaps hasn't had the level of attention and level of funding that it deserves. And one of the challenges when it came to the pandemic is, whilst it was relatively straightforward for the reporting network to identify, what was going on in the NHS hospital trusts, 400 hospital trusts, the care homes are many, many more in number, and there wasn't that kind of reporting, and there wasn't that kind of structure, so that it was obvious and clear as to what was panning out. I mean, roughly 12,000 care homes, a variety of different sizes, many different individual independent care homes, as well as some of the brand care homes that you will know very well. But roughly about somewhere in the region of 400,000 plus beds. And people are there needing support, needing care, and this happening all at a time of a pandemic. And the care homes are obviously spread across the whole of the UK. There is this variety, all from, I think there are a couple care homes which are literally a single bed, but all the way up to more than 100 beds. And that breadth leads to particular challenges when it comes to trying to cope in a pandemic, as we will see. Now, 2020, or more particularly what I'm going to be talking about kind of from March, April of last year to April of this year, there's no doubt it was a annus horribilis for care homes. Obviously, care homes, people go there for a number of years when they need very significant care, so mortality rates are regrettably relatively high. But what has happened over that year is roughly 30,000 extra deaths were registered from COVID. And as we'll see when you go through, it's really important to recognize it is that additional burden, that excess burden, which is associated with the pandemic for the reasons that will have been covered in previous talks relating to the particular challenges that COVID faces, particularly related to those who have cardiovascular disease, diabetes, and for the elderly. And this chart here shows how the relative percentage of deaths due to COVID have fluctuated over the year. And actually the situation is probably worse in those earlier months than is indicated here, because in those earlier months, first of all, reporting was tricky, but also the level of testing was not really adequate to pick up all those deaths that really were due to COVID. But it's not just those who tragically have lost, it's also those in the care homes who have suffered. And the level of isolation necessitated by trying to reduce the outbreaks, to reduce the spread, leads to levels of isolation, depression, confusion, which are very distressing both to the individual, but also to the families. And that is particularly tricky at a time when so much is changing with face masks, with restrictions. Trying to communicate and understand what is going on in those situations is very, very difficult indeed. But this chart here gives a little bit of an illustration building on what I previously was sharing of the way in which the number of deaths progressed over the year. And as you can see, there really does seem to be a very high number, expectedly high number of non-COVID deaths right at the beginning compared to later on. And that probably does reflect the fact that a number of those supposedly or assumed to be non-COVID deaths were actually directly or indirectly caused by COVID itself. But this pattern of recovery from COVID and then the second wave that we saw related to the B117, the Kent variant, and the spread, obviously this has necessitated a number of different lockdowns. And as we emerge now from the last, hopefully, of these lockdowns, once again, we are faced by these challenges, which we do not wish to the virus to spread further. And so this rather contentious policy that when people leave care homes, when they're finally allowed out to see family members, when they go back in, the contention is that they have to isolate for 2 weeks. And that is obviously adding further to the sense of frustration and indeed the isolation for those individuals. And it's trying to find the right balance between the risk to individuals and the risk that's being spread around those care homes. But going back to this idea of, what happened towards the beginning and to what extent were the care homes overlooked or kind of forgotten in the overall discussion. We had briefings right at the beginning of February to NHS leaders, and then letters coming out trying to free up as much capacity within the hospitals because of the worries about the peak numbers of cases that will be seen and indeed the Nightingale hospitals, etc. It wasn't until the kind of 15th of April where there actually was a formal action plan for adult social care. And one of the particular problems, one of the particular challenges was that in trying to free up the hospitals for the impending number of cases, many patients were discharged from their hospital beds back to care homes. And that happened at a time when there really wasn't sufficient testing and there wasn't sufficient policy to try and have some type of, intermediate step. And therefore, a number of people who had COVID in hospital were effectively coming back to the care homes. This limited testing has obviously now built up to enormous levels with lateral flow testing and PCR. But the lack of testing and the relative lack of PPE in the care homes in part reflected capacity, but also in part reflected this coordination, which was possible within the NHS because of its setup, because of its structure, but because of this multitudinous nature of the care homes, didn't really happen until later. And then when we realized quite how important asymptomatic testing was for trying to control those outbreaks, then clearly, clearly it would be helpful to have asymptomatic testing, to have regular testing, and that was posited back in May, but it took some time until it was available for both care home staff and care home residents. And this slide here gives you a little bit of an illustration of the key dates that happened along this progress, and also the key injections of funding and the release of particular action plans by government. There's no doubt that during COVID, a significant amount of money has been provided, but that money is and was desperately needed. And indeed, there's been remarkable advances in terms of the way in which data is collated together and provided readily for analysis and understanding. We had daily reports on numbers of deaths going back to March from the NHS. It wasn't until we got into April that the Care Quality Commission was able to provide that level of detail and the breakdown by regions and by age. But to give a little bit of an illustration of how that variation happened, because it wasn't happening the same everywhere, I've got two slides here which try and look at individual counties, individual local authorities. And this first one is just looking at the additional level of mortality. So on the left we have here excess mortality per mil, and this is across the entire population. And what does this say to me? Well, it says that actually there was quite a dispersion of additional mortality by different authorities, and some authorities were harder hit than others, and in part that reflects where there's an older population and where there were more care homes, and we saw the concentration of care homes, and an older population, given the nature of COVID, is associated with a higher mortality rate. But if I compare this slide to the next slide, where I'm switching from excess mortality to the COVID, non-COVID distinction, you can see that you'd expect there would be a kind of degree of kind of coming together of those different points. There is, but there is still some spread. So COVID was a more significant issue for particular local authorities. And right here you can see Bournemouth and East Sussex, where somewhere between 80 and 90% of the COVID mortality compared to the non-COVID mortality. So clearly very significant variation between different authorities. And in part, that reflects the nature of the outbreaks. And here we have a very colorful slide, which is showing the different outbreaks that were occurring in different regions, in this case, over the time of the pandemic, and mainly focused on the first wave here, and then moving into summer here. And you can see that, you know, the various different regions are all contributing. There were outbreaks everywhere, but those timing of those outbreaks and exactly which individual health care home was actually affected varies. And another way of looking at that was to look at the individual care homes and say what proportion of care homes actually had an outbreak, so multiple cases of COVID, compared to those which either had very limited or no outbreak at all. And this kind of slide gives an illustration here, somewhere between a third and a half of care homes were reporting outbreaks, and the rest were not. So, you know, what is the underlying factor that led to these particular care homes having the outbreak or not? And that was in respect of England. Clearly, this type of analysis, clearly this type of insight has been now gathered across the UK. So I'm going to talk about Scotland, and later on I'm going to talk about international comparisons as well. So on this first element, though, this is all the care homes. I think it's 190 care homes in a particular health board, or sorry, within this health board, a fraction of the 190. So this is showing the experience of those care homes that didn't have an outbreak, and you're looking for the kind of dark bluish color, which indicates COVID deaths, or deaths that were registered as COVID. And clearly there isn't much in the way of COVID mortality, and the figures look, if anything, for much of the period, somewhat underneath the all deaths average over the last 5 years. But if we switch to the next slide, and now we look just at those care homes where there were significant outbreaks, then once again, this is mainly focused on the first wave. You can see the very significant additional number of COVID deaths and how we are well in excess of the average over the 5 years. So clearly, the care homes that had the outbreaks are where we see the very large amounts of additional mortality, and others were somewhat spared. Now, that may seem kind of self-evident, but if we go to a kind of deeper level of trying to understand where the infections were, as opposed to, you know, outbreaks and indeed the mortality thereafter, there have been a wide range of different studies. And one of those studies, which is now still ongoing, is the Vivaldi study. So named, I'm assuming, because of the fact that there was a partnership between UCL and Four Seasons Healthcare, hence Vivaldi. But the Vivaldi study has attempted over a period of time to look at a number of different key topics. First of all, who was infected, staff and residents. Second, whether people are currently infected, and also, because information is gathered on blood serum, what are the levels of antibodies and how effective might those antibodies be? Obviously, antibodies are only one part of the immune response reaction to COVID. And what the first of the Vivaldi studies indicates quite clearly is obviously it's a small percentage when this study was being carried out that were positive, but it also highlights a couple of very interesting, important factors. One is the number of people within the care homes who were asymptomatic, but were proving positive on PCR. And these were probably all going to be PCR tests rather than lateral flow tests. And second, also the balance between staff and residents. And when the analysis was done to look at various different homes, it was quite clear that there were a number of factors that were particularly important. We've already mentioned, I've already mentioned the fact people returning from home to hospital, returning from the hospital where they've been treated back to the care home as a source of potential infection spread. Another area which was very important was the extent to which individual staff members might be working at more than one home. And that was a well-established pattern that agency staff dealing with kind of levels of additional need or as part of standard practice might be working at more than one care home, and therefore the possibility, regrettably, of spreading the COVID from one care home to another, obviously related to the asymptomatic nature of the disease. And if we look at the kind of breakdown that came from one particular study that was reported by the CQC, the Care Quality Commission, if we start with the kind of unfettered analysis without looking at the interactions, you get a sense of how many of the beds are concentrated in large homes, and indeed that the majority of homes are being run on a for-profit, a commercial basis, rather than a not-for-profit public basis. But when we look in terms of breaking that down by bed capacity, and we try and allow for some of those factors, then we get this type of analysis. And I cast your eye down around here, where we're talking about the relative number of excess deaths for for-profit and non-profit, and the levels are very similar. And similarly for the branded care homes compared to some of the independents, they're also very similar. But at least for nursing homes, some differences you can see for residential homes. But when we look at the size of the care home, having allowed for capacity, the size of the care home, the larger the care home, the greater the excess mortality. And as you expect, that greater opportunity for spread and that greater opportunity for outbreaks. Now, much of that is focused on the first wave, but clearly the second wave that we started to experience from October onwards, and then particularly with the B1.1.7, that variant spreading so rapidly across the UK, we had clearly a second wave. A second wave, which actually, obviously, normally we expect additional mortality because of influenza during the winter months. This year, we didn't. And obviously we did from COVID. And so this slide here is looking from the beginning of the year up to kind of relatively recently in April, and it's data from the ONS, which is trying to look at the number of COVID registered deaths compared to the non-COVID deaths. And during this period of time, testing is full compared to the first wave. We have a much better sense of those who are actually probably suffering and where COVID was instrumental or very important in eventual mortality. And you see two clear patterns going on. First of all, this kind of wave of increasing reddish colors indicating the surge of COVID deaths. And then you see this rapid fall off. Now, there clearly are a number of factors going on here. First of all, this is the time when we have the rollout of the vaccinations, starting with Pfizer and then moving on to AstraZeneca. And the priority groups put forward by the JCVI clearly are focused on the elderly population initially, and then those with medical conditions. So one would expect to see a more rapid reduction in the excess mortality from the older population, and then it percolating down to younger populations. And the fact that there is somewhat greater symmetry across the age groups than you might have expected reflects the fact that obviously at the same time, we were benefiting from the lockdown, which was shutting down the ability of the virus to spread, and obviously shutting down the ability for care homes to be affected. And throughout this period of time, many lessons had been learnt in terms of how staff can work in one particular place. PPE was sufficient in numbers comparison to the first wave. And so those combined effects and the fact that we're moving back into, although sometimes it doesn't seem it at the moment, slightly warmer times, that leads to a reduction in the number of COVID infections and a reduction in the number of COVID deaths with the lag that we've all become familiar with. But this pattern of obviously the lockdown, the vaccination, and the changing seasonality together lead to the type of overall effect that we see here. Now, almost everything I've said up to now has been focused on the UK, on England, some parts of Scotland as well. I wanted to take this opportunity to share a little bit in terms of the learnings there have been from care homes internationally, many of which have been very helpful in terms of guiding what it is that we should probably be doing to try and prevent outbreaks. But equally, in each of those countries, or in many of those countries, there have been similar catastrophes and annus horribilis in terms of the numbers of individuals in care homes who unfortunately have died. And one of the great things that has come from the pandemic, as we can see some type of silver lining, is the number of groups that have come together to share information. I happen to be part of the COVID-19 Actual Response Group, and at the same time that we were trying to gather data together back in March 2020 and starting our series of publications, another group based on the International Long-Term Care Policy Network, we're putting together the LTC COVID platform. And those of you who have not come across this, I would hope that most of you have who are interested in the area, but those of you who have not, it's an astonishing level of commitment and information that's been gathered in a very short time by a very limited number of individuals initially, and has become an international resource of great value. And many different studies are available from this resource, and not just those that are completed, but also those which have been set up, and many research projects have been set up to look at how different aspects of care homes and different aspects of long-term care have coped, have fared during the pandemic. And those cover a whole range of different aspects. Obviously, we're a little bit more focused on mortality and quality of life, but the operation, the way in which care homes function, and the underlying rights of the individuals is also a topic of much discussion on this website. And similarly, it covers a wide range of different countries with, as you will see if you go onto the website, a succession of different webinars where international experts have shared their perspective on what happened, where the lessons were, and what needs to change going forward. And sometimes those are kind of comparisons across different countries. Sometimes it's looking at the interaction with the waves and the different vaccines. And sometimes it's looking at the actual workforce and what the implications are for the workforce, because clearly, in a situation where you have such an overwhelming level of additional care needs and the possibility of staff members being ill, then the stress on those that remain to look after those that need care becomes enormous. And it is one of those things that as we went through the pandemic became more and more aware of quite how difficult the situation was in care homes around the world. But the patterns are not uniform. And in part that reflects the different decisions, policy decisions which were taken when it regards to how care homes were used when we're trying to free up space in the hospitals. But it also reflects the fact that there are differences in terms of the way that COVID deaths were recognized and recorded, and differences in terms of which groups were most affected. And so you get a range of different percentages in terms of these comparisons. But as you can see, the comparison over time, as we went through the various different waves, are more comparable. But as you can see, all the way from Canada, where maybe 80%, down to Singapore, much lower numbers, excess mortality, additional mortality was taking place and needs to be understood. And this pattern, this is looking more at the kind of European level, this pattern of deaths in care homes. I've been talking so far principally about the concept of, deaths versus from COVID versus non-COVID within the care home, because of the age of the individuals and the effect that COVID is so destructive at older ages, and particularly those with pre-existing conditions. The proportion of deaths across the population that are represented by those in the care homes is high. And you can see how that varies between different countries. And one of the great ongoing pieces of work done by LTC COVID is bringing these different international data sets together in one place, a heroic task for one which we are definitely grateful. But you do see this broad pattern, which is that the mortality in the care homes on average is running in tandem with the overall mortality, obviously at a higher rate, but in tandem. And therefore you get this graph where effectively it's a kind of northeast direction in terms of the balance. But within any particular column, there is this more significant variation. And one of the countries where a lot of data has been collected, a lot of data has been put together to better understand what are the underlying driving factors, is the US. And as we have the LTC COVID across the world, within the US, one particular group sponsored by The Atlantic effectively put together a COVID tracking project. And within that COVID tracking project, they created a long-term care COVID tracker. And that was tracking over time many different aspects related to vaccination, additional mortality, and overall state of care. And where the US was perhaps different to other countries was that they had a very significant wave in the summer as well. And we'll see in a moment where their focus was in terms of locations, in terms of region. But the challenge remains trying to identify those that were dying with COVID as opposed to those that were not. Now, I mentioned this regional difference, but the regional difference in the US reflected the different waves of the care home. And so here we can see 4 different regions within the US. And as we know, the biggest impact at the beginning was in the Northeast, and we heard much about New Jersey and New York City and state and the effect that it may have. And the second is that in the summer months, there was a wave of infections and mortality, particularly in the more southern states, possibly driven by the kind of spreading of that as people made more and more use of air conditioning in the very hot climate. And then towards the end of the year, we had the building third wave. And so those waves across the country are reflected in the waves we see in the care homes. And I see a question that's come in, which is that obviously the mortality between different countries varies, and in part that reflects 2 things. One, that the people who are in those care homes, what their level of need is, and second, obviously, the way in which that care home stock and with those care homes are used. And that's something we'll come on to later when looking at some of the design issues or challenges that care homes have faced. But thank you for that reminder. Now, I mentioned earlier on about vaccination and how, the vaccination and the kind of seasonality and the lockdown combined to be reducing the number of deaths in care homes we saw in the UK. Here's an equivalent chart for the US. And here, obviously, there's been less in the way of restrictions more recently. The pattern is more evident when you compare, and just to be clear, when it says non-nursing home residents, that doesn't mean a lesser category, that's talking about the entire population. So here we're comparing how the pattern of mortality has been in the general population compared to the nursing homes, which were one of the groups which were targeted earliest for vaccination. And you can see that reduction, which is hypothecated to be due to the vaccination. Obviously in the US, it was Moderna and Pfizer rather than Pfizer and AstraZeneca. And this is also a good illustration, once again, of another group who have been instrumental in providing so much information, so much valuable information about care homes, namely the Kaiser Family Foundation. If you go on their website, you can get breakdowns of how the different care homes, the distribution across the US, the number of beds, the levels of activity, and it's been an invaluable data source to try and better understand what happened across the country and what factors seem to be particularly important. Now, I mentioned earlier on about the importance in trying to understand outbreaks because we saw how correlated they were with excess mortality. And so clearly now and going forward, we wish to prevent further outbreaks. And it's interesting how a number of guidance documents have come out during the pandemic, but if we go back to before the pandemic, there already was a kind of a general philosophy of trying to increase preparedness and to increase the level of infection control in care homes, as exampled by the Enhanced Health in Care Homes framework. And that goes back all the way to prior pandemic in 2008, 2009, but also a recognition that we have a changing stock of care homes within the UK. And that's something I'll comment on a little bit later, but it has very important ramifications for social care needs and for how we look after people in the future. Now, what are the different ways in which we're trying to prevent the outbreaks? Now, I have a picture up on the right-hand side there, which obviously has vaccination. So vaccination is one of the best ways, and more recent studies have confirmed that the level of improvement in transmission from vaccination, preventing both the proportion of symptomatic and asymptomatic cases, as well as we know the much stronger prevention against serious complications and mortality. But it's not just the vaccination. There are other steps that care homes have taken. We have seen, the routine testing, twice weekly. But another element, and this is obviously benefited from the insights we've got from King's College London and Zoe about using the COVID symptom study to be aware of the variety of symptoms that weren't part of the initial classic triad and ones that are particularly relevant for the elderly population. So lethargy, lack of appetite, and delirium. These are much more prevalent and even in some cases more important than the classic triad, and being aware of those is helpful, although obviously it can be very difficult given the nature of conditions that people have in care homes to always make that distinction. Now, care homes tend to be run at fairly high occupancy. Indeed, several of the leaders of the care home brands were kind of putting forward that when they were instructed or needed to take in people from hospital, maintaining a high level of occupancy was consistent with the business model. But what we need to do to try and prevent outbreaks is to see ways in which we can try and reduce that maximum occupancy, and as importantly, to try and segregate populations. And as we've seen in hospitals, it isn't just those who have confirmed COVID, it's trying to work out those who might, and keeping those different groups separated from one another to prevent the likelihood of outbreaks. And one way that can be done is by effectively providing these kind of intermediate centres where you're slowly managing the release back to the individual's own home, their own care home bed. And that obviously requires a degree of not just one swab, but potentially multiple swabs, given the kind of period of time over which the virus develops. And as important is that all this information is digitally collected. And that digital collection obviously helps in terms of supplies of PPE. It also identifies outbreaks that may be about to develop. And those outbreaks, obviously, there's a possibility that an outbreak amongst care home residents is going to either have been caused by or cause an outbreak in care home staff, and therefore at the time when people need the most care, there will be a deficit. And so the idea of kind of rapid response teams where people effectively come to a outbreak area and provide that continuity of care is absolutely key. Clearly that requires additional staff, that requires additional cost. I mentioned at the beginning, obviously, the use of agency staff, but more generally, that staff members may have looked after more than one care home. So trying to limit the number of people who are going between care homes, and particularly when it comes to healthcare workers who need to visit to provide healthcare needs or services of support, to what extent can that be done by telemedicine? To what extent can that be done virtually? And the increasing use of telemedicine is obviously something which we've seen many instances in primary and secondary care. In care homes, it's equally important. But amongst all this, we must remember something else, which goes back to the point relating to isolation. And that's that this can be, particularly for individuals with a variety of conditions such as Alzheimer's, a very stressful, a very isolating, and obviously exacerbating mental issues. And therefore, to the extent that these type of segregations, these type of separations can be done in such a way that it doesn't intensify the isolation. So visiting with PPE for visitors, degree of social distancing, that can lead to a better overall outcome than just the application of the segregation in its rawest form, which exacerbates people's feeling of isolation. But it's not just about what we do with existing stock. It's also about the need for care homes to change over time. And one way in which they could change over time is their design. And it goes back to what I was saying with care. So what I was saying with Hartwig Oaks, where it was deliberately set up right from the beginning as a community, where the intention was always to go back, if possible, to your individual bungalow. You'd receive care, acute care, and then you go back to your bungalow. The challenge, obviously, with COVID is that if you have that kind of level of mixing because of the centralized care center, then you have the possibility of more traffic, more footfall, and therefore more spreading. And this particular plan you can see here, that's known the household or green care model, is designed to effectively to do a number of things. First of all, you're trying to limit the number of people, staff members, and indeed residents in a particular location, limiting the possibility for outbreak, limiting the possibility for unnecessary spreading. But you're also trying to maximize a number of other areas. First of all, providing that interaction, that kind of avoiding social isolation. So, first of all, the visibility of the central area from the different rooms, the accessibility of it, the kind of wide open views, and also this kind of mentality that this is a group of residents with a dedicated staff that they will know well, therefore kind of leading to a greater degree of familiarity. And so a very, very good question coming in terms of care homes for those which were not for the elderly. And much of what I've talked about within the overall slides does focus clearly on the care homes which were particularly focused on looking after elderly patients. But clearly there are a variety of other care homes which are looking after people with medical needs at younger ages. And some of those medical needs are also strongly associated with increased levels of risk for COVID. But some just need a level of high support. And that obviously is a challenge when you're trying to combine this kind of difficulty of trying to prevent spread, but also providing the care at the same time. And therefore, things like PPE, things like trying to restrict the number of care homes that are covered by particular healthcare workers. I've started to kind of touch on this idea of, the way in which care homes can change. I just want to reflect a little bit on an external dynamic which has happened at the same time. Clearly, the experience of seeing the care homes going through this traumatic, terrible experience of so many more people dying has initially had an effect in terms of people wanting to see if they can find some way of keeping their loved ones with them at home, and therefore a greater desire to domiciliary care. And in fact, going back to one of the earlier slides, there are more people receiving care at home, clearly, than in the care homes. And so occupancy levels have fallen, although they are starting to recover. Now, the fact that existing care homes tend to need to run close to maximum occupancy means that you have this challenge in terms of the financial model. But it's not just the occupancy, it's the very nature of trying to deal with preventing future COVID outbreaks means that there are additional costs. We talked about staff in dedicated units. That means more staff. Obviously, these kind of idea of rapid deployment, that's additional staff. And making sure that we provide sick pay to deal with staff absence, additional cost. And indeed, the very PPE itself, which is necessary when you're moving from care home resident to care home resident, means that just as in hospital, there is a significant additional cost. So these additional costs are additional challenge, but one that need to be taken into consideration when thinking about the overall costs of social care. And for some time, Knight Frank has been producing a series of research publications which look at the stresses that individual care homes are under. And they identified in particular that it's somewhat the smaller, fewer numbers of beds, older care homes, which are most at risk. And in part, that's because they tend to be more the independents, and therefore they don't have large brands and many, many different care homes. But the second is that some of the stock is somewhat older. And if you look at that, the numbers of the older care homes who have wet room provisions, so the ability to have your own private bathroom, which obviously is another factor which is important when trying to prevent spread of COVID, and also is an increasing expectation of care home residents, means that there is a greater level of risk and a greater likelihood of being unable to deal with the occupancy loss that we've been talking about. And this continuing desire, expressed first in the pandemic, to try and look after loved ones from home, here from a YouGov survey made very clear that if there was a choice, a strong preference over home care over care home. But there is a reality in that, which is, care homes are through their nature able to deliver services and support in a more comprehensive and efficient way than is necessarily possible from home care. And so there are challenges over staffing and challenges over integration with other parts of the healthcare system. It can be quite difficult to ensure that you are getting as much attention when you need it as if you're a care home able to be better linked into the healthcare system. And what's been interesting is this greater drive towards domiciliary care obviously goes at the same time as increasing use of telemedicine. And in a number of countries here, I've got an example of China, the increasing emergence of what we're calling virtual care homes, where effectively the services that you would expect in a care home or the support is being provided to your house, either virtually or through delivery. And clearly there's some huge challenges here over staffing and quality of care. And obviously it may work in certain countries, but not others, given the unit costs. But the idea of your home being turned into a virtual care home through greater delivery of the services, greater levels of support, greater levels of monitoring is something which is increasingly seen to be the case. And this brings me to the final piece within the overall presentation, which is throughout I've been talking about the challenges that care homes and the wider social care have faced because of the pandemic. But the reality is that we have been facing challenges with regard to funding of social care for decades. As the actual profession is well aware and has been closely involved in the variety of different commissions and the variety of different committees that have been set up. And one of the most recent committee reports came to the conclusion that not just the care homes, but looking across the spectrum in terms of adult social care, something of the order of at least 7 billion was needed in terms of additional spend by 2023-24. And that compares to current spending of 20 billion. So it's obviously we have an increasing elderly population. We also have, the need for staffing costs and staffing to increase, and a general desire that we don't provide a situation where certain individuals, through no fault of their own, are facing catastrophic costs. So, what is the right level of capping to try and strike that balance between providing care and protecting assets that have been built up over time? And that has led to a white paper from the Department of Health and Social Care, which somehow took, what had already been put in place by the CARE Act 2014 and rebooted it to reconsider what may or may not happen. And there's a consultation process going on right now in terms of that which has already been said. But the white paper speaks very much in terms of processes and approaches. The fundamental underpinning issue is the huge amount of additional funding that will be necessary. And there is this kind of variation between different parts of the UK, and obviously variation depending what level of care you need. So that, if you go into a nursing home, then your assets include the house that you've left. Whereas if you're receiving that domiciliary care, typically your assets are not, when it comes to means testing, including the assets or your primary residence. So the cost of care is high and obviously will increase with some of the changes that are necessary, not just in terms of preventing outbreaks, but this rebuilding of the stock and doing it along modern lines with the wet room provision, etc. And that has to be paid for through a variety of different sources. And one of the areas that the Institute has and various different working groups have commented over the past is the various different type of insurance solutions that may help some individuals in contributing to that cost or planning for that cost. Whether that's in terms of investment options, vehicles, or releasing value from your house. And obviously those type of solutions need clarity as to where will the cap be and how much funding will be required. And as we go into a situation where some care homes may find it impossible to cope with the additional demands put on them and requests and requirements and additional staffing costs, the costs of care homes will go up, and the kind of potential for what might be delivered at home will similarly increase, but there is a less clear signal from domiciliary care as to when that event has taken place. You haven't gone into a care home, so clearly the insurance solution needs to be more flexible and therefore requires greater kind of planning. But bringing this maybe to a conclusion, the important piece here is that what COVID has done is it has exposed a lack of investment, a period over which, unfortunately, care homes became vulnerable to precisely the kind of perfect storm that COVID presented, where at the same time that they were hoping to try and prevent the very elderly in our population from being exposed, hospitals were effectively having in the UK to kind of send people home to get ready for the peak. And so it's an opportune moment to us thinking once again very seriously about how it is that not only do we fund social care, but what is the right model and how can it best be delivered, and most importantly, what that says about us in terms of our provision for social care for the elderly and for ourselves going forward. I think we're getting very close to the end of the time. I don't see any further questions that come through. If anyone does have any further questions, then I'd be very, very happy. I think I provide my details. So if people would like to send a question, then I'm very happy to kind of come back with answers and to share those answers back in terms of the kind of the final presentation so people can see it. With that, I'd like to do two final things. First of all, thank you so much for taking the time to listen to me talking about what I think is a very, very important topic, even as we do emerge from the pandemic and things are improving dramatically within care homes thanks to vaccination. And then the second thing is to thank once again the ICAT committee for bringing this series of webinars to fruition, and to recommend wholeheartedly that tomorrow there are two more sessions, one from a very dear colleague, Stuart McDonald, who has been instrumental in the actual profession in bringing so much attention and bringing so much engagement from outside the actual profession in terms of what actuaries can provide, and then taking a much more reflective look on a whole range of issues about how the COVID pandemic has affected us and where we go from here. But for today and for now, thank you very much, and I wish you a good rest of your day.